פרוצדורה לוחד לשבע.
Hey, Julie, how you doing?
Good. How are you doing?
Good, good. So you're gonna break it up with Antonio?
Yeah,
today?
I'm gonna go first, and then he'll go. And we're doing our own screen shares.
Okay, that's fine.
Yeah,
I just wanted to
thanks.
check. Thank you for presenting.
Oh, my pleasure. Thank you for having
Yeah.
me. Should I share now, or did you have something you wanted to show beforehand?
No, just gonna give everyone like to 1 of 5, and then you can start after that.
Okay.
Yeah, and then
I'll
that's
just
pretty much it.
Okay, great. I'll just share my
Yeah.
screen just to get it set up.
Okay, all right.
Can you see that?
Yep.
Great.
Okay. I'm gonna do a mic check right now, make sure everybody can hear me. Hey, Julie, long time no see.
Antonio, I think your mic isn't working. It's muffled.
Okay, thanks.
All right, so we can get started. So thank you again, Antonio and Julie, for presenting today. The Yale group will be presenting the group to us. So without any further ado, go ahead, Julie, you can give us a start.
All right. Hi, everyone. I'm Julie Leviter. As Henry mentioned, it'll be Antonio Riera and myself presenting from Yale. So thanks for having us. All right. So our first case, we have a 16-year-old woman presenting with shortness of breath. Her COVID PCR is positive. She's been having symptoms for 4 days, fever, cough, worsening shortness of breath, and pleuritic chest pain. So she was sent in for a chest x-ray. She has a history of exercise-induced asthma. She's on OCPs. Her vital signs are as shown. She has a heart rate of 90, respiratory rate of 20, and is satting 99%. And then on exam, she's persistently coughing, and has decreased sounds at the bases. So we use our POCUS, and you see here on the left side and the right side compared with the curvilinear probe. And you see on the left side that she has these pretty focal B lines. It's really just in this one spot in her left lower lung field posteriorly. And you see that sort of classic pleural thickening. Can you guys see my pointer?
Yes, we do.
Great. That pleural thickening and irregularity that we often see, that we describe with COVID. And then you also see a little bit of air bronchograms sort of popping into the picture later in the clip. On the right side, you just see A lines. There's no effusion bilaterally. So we got some labs. Here's her CBC, pretty unremarkable. We did get a D-dimer because, as you know, with COVID, we have that risk for hypercoagulability, and her D-dimer was 0.55, and her EKG was normal. And here are your chest X-ray findings with, and read as bilateral perihilar interstitial prominence and patchy opacities in the left lower lung, concerning for pneumonia. So just curious, opening up to the group, how many of you would, first of all, go down the PE route? Second of all, how many of you would attribute all of this to COVID? And how many would give antibiotics additionally with concern for a superimposed pneumonia?
Julie, did you by any chance do I know it's probably not as specific as we would like it, cardiac on this patient? We're thinking PE.
Yeah, so the focus was negative. It was a normal focused cardiac ultrasound.
Okay.
Julie, I might have missed it. Did you say that there was fever in this?
Yeah, she had fever for 4 days.
I don't know. I think looking at those, the white count in the clinical picture, I might actually just avoid antibiotics at this point. I'm not super impressed by that little spot there, but maybe I'd follow her clinically. I have some perspective, having worked in the COVID hospital here in Providence, and that's a pretty typical chest X-ray for most of the admissions that we're seeing.
I heard about that field hospital.
Lots of stories to tell about that.
Erica, would people get admitted for this chest X-ray if their vitals are otherwise normal and doesn't require oxygen?
No, well, field hospital is a little bit different. The field hospital, number one, we're seeing adults only. Number two, the people that are getting admitted always have an oxygen requirement. So it's either oxygen requirement or unstable housing, or can't go back to their group home or to their skilled nursing facility for whatever reason. And so they're just in a holding pattern waiting for something to happen.
Gotcha.
Lots of little stuff. But the patients that are like there because, not for social reasons, it's not just the chest x-ray, it's like oxygen need, clinical picture, almost always oxygen need.
Right. I mean, I'm a little curious for the group, how many people would have gotten a chest x-ray on somebody who is not hypoxic and just coughing and has COVID?
We have a culture in our community where a lot of patients are sent in to the ED specifically /only to get a chest x-ray. And then we sort of change the plan as we see fit, but that may have contributed in this case.
Gotcha.
And Julie, the ultrasound that you showed on the left side, is that the area that's on the x-ray? Because like it didn't like correlate like as much of a big consolidation or like on ultrasound at least, if I'm not mistaken.
Yeah, it's true. That ultrasound finding correlated with this location on the x-ray in the left lower posterior lung field. And you're right, it wasn't like it wasn't as a large consolidation that we often see with shred sign or anything. It was those focal B lines with the pleural irregularity and a couple of air bronchograms. So we were just curious about the incidence of bacterial co-infection with COVID pneumonia. And there's actually a meta-analysis that was published recently, as all of this COVID literature is. And it found a low incidence of bacterial co-infection in hospitalized patients with COVID-19, so 7%, which is less than is even seen with the flu. But needless to say, based on
Oh, is Julie still there?
No, I
Julie
think
is
it shut off. I
frozen.
thought it was my phone initially.
This is the love-hate with teleconferencing in
Let's see if she
action.
comes back as a cat.
I'll give her a few seconds. If not, I could jump in. But we have our cases on separate presentations, so I'd have to share my screen.
Last time I think it was just for a little bit and she came right back. So yeah, this happened to her last time, I think too.
This is Matt in South Carolina. I'm curious. I probably wouldn't have even rolled my ultrasound machine in there, just if she was known COVID and like stable vitals and whatnot from a machine exposure infection risk profile. I know back in the spring, at least, we were all like, at least our institution, everybody was like crazy concerned if it wasn't going to change management to, avoid one more vector effectively. I will say we've definitely laxed up on that, but I'm curious, in someone who was otherwise like vital, stable, how many people would have actually gone and even looked?
I just because of other patients I had, I always tend to just look, just because a couple of patients I seen that gotten worse, and all of a sudden I found some like that ventricular dysfunction. So I tend to be more precautious just with them, just because I had bad luck with whenever they come in with a few days of cough and fever and in the setting of COVID.
I agree. I look at the heart as well in that clinical scenario. Because, and also from my understanding is that the cardiac dysfunction can precede sort of the severe respiratory symptom. Like it can happen earlier on in the illness.
Yes, I found out too, yeah, Julie. Yeah, so POCUS has saved me in a couple of patients. So maybe I'm overdoing it, but yeah, whenever I have a high suspicion, I bring my old buddy ultrasound to come in and help me.
All right, I'm going to go on to the next case. Sorry about that internet snafu. So we have a 9-year-old girl with vomiting and right lower quadrant pain referred to the ED by the pediatrician to quote unquote rule out appendicitis. So she had an acute onset of the symptoms of vomiting for about 12 hours, right lower quadrant pain, no appetite. She was afebrile. And in an exam, she had rebound tenderness locating to her right lower quadrant. So here are her labs. You see that she has an elevated white count of 12.9, 83% neutrophils. So ever in search of an inflamed appendix that we could capture on ultrasound, we pulled the machine into the room and went right for the right lower quadrant, right? So there's actually an interesting article worth a look. Both of its authors are in this meeting. It was just published this last year. So as we all know, any rule out appendicitis is also a rule out gonadal torsion.
Oh boy. We need to do a GoFundMe to up Julie's bandwidth.
I told her to get a PC. I've been harping on the PCs for the last decade now, but everybody's doing Apples at our shop other than yours only. I suffer from the audio issues, but easy to remedy.
I'm gonna agree with you on that, Antonio. You know, I always asked me, I was like, hey, I don't like apples.
I thought it was a requirement to be in the POCUS community. You had to be all Apple.
There's more P's and C's in POCUS, and well, I guess it's a tie, 2 P's.
Actually, before Julie gets too deep into this one, did that last case end? Was there more stuff that we should have her finish up on?
I think she just showed amoxicillin and home.
I think the treating team ended up putting her on a course of amoxicillin and dispositioned home without any adverse outcome other than who knows with the penicillin on board.
Hey, it's Hannah Sneller I'm in Omaha. Our ID team with these COVID kids is really frowning on us and community pediatricians prescribing antibiotics in this situation. So I guess I would disagree with the management personally, especially with all of the data that we have from the last 10 months now.
Yeah, would agree with that too.
Can you hear me again?
Yep, you're back on.
I'm so sorry. I've been working on this internet thing and apparently it's still an issue. Sorry, what was the last thing that was heard or said?
Go now. You just pull up the graphic you have on about
You were bragging about your publication, Julie.
Oh, right, that's where I was. So I've actually since changed my algorithm, and anytime there's lower quadrant pain, I jump right to the suprapubic view. And this serves a couple of purposes. First of all, I'm prioritizing looking for free fluid in the most sensitive place of the pediatric pelvis. And I'm also checking the bladder volume.
I wonder if it's better for her to stop showing her video and just call in while she advances the slides, if this is too much for her bandwidth.
Yeah, I'll ask her that when she comes back on and see what she thinks.
Antonio, do you want to take over in the meantime? Is that, or is it?
I just tried to share my screen, but I'm getting message that we can have two individuals simultaneously sharing screen.
Sharing. Okay.
Oh, hold on.
Yeah, try now though, because I think.
Yeah.
Yeah. There you go.
All right. So just in the interest of time, and if we have some time at the end, although I have tons of cases, we'll let Julie finish up. You guys can see the screen okay, with the logo?
Yep.
Very good. So I try to come up with at least sort of like a theme for this session. You know, I think we've done a lot of roundtable discussion about some really amazing pickups and, you know, really bizarre zebra type cases. So I thought I'd reel myself in a little bit and just go over some maybe more day-to-day bread and butter type scans that we do. So I put together a list of my top 5, which is really a top 6 because the joints aren't here, but the top 5 reasons for Antonio to pull up his POCUS machine include cases where there's unexplained dyspnea, with or without chest pain, obviously soft tissue swelling, trauma, urine retention, and then abdominal distension with some degree of abdominal pain. And we do these are all actually fresh and new from the last time we presented, which is a testament to how POCUS is really, I think, impacting our workflow. And I think there's going to be enough for discussion, both on the clinical side and some administrative issues as well. So we're going to start with a case of a 9-month-old who presented on an overnight shift for me with respiratory distress. This was the 3rd visit for the same illness, came with mom. On the first day of illness, was tested for a viral panel, not quite sure why. The rhinovirus test was positive, and on the first day of illness, also had a chest x-ray done, which was red, and you can see here, peribronchial cuffing, pretty nonspecific, small airway inflammation, which we get all the time. So when we saw it, was day 3 of illness, was still having low-grade fevers, was having cough, post-tussive emesis, and definitely was having some increased work of breathing. Mom was sort of hyper-aware about asthma because she had a history of, but this 9-month-old hadn't been trialed on any medications for asthma. And then here are the vital signs at triage: some tachycardia with fever, some tachypnea, and the oxygen saturation was okay. And on exam, this infant was definitely distressed, definitely having some retractions, and no clear crackles or wheezes on exam. So I actually wanted to check. We've had so many, and with MISC in the picture, we brought the machine to mostly check for cardiac function initially, but this little guy was laying prone at the time. So I said, well, let's take advantage and look at the lungs. And I'm trying to figure out, there we go. So you guys can see the video clip going here. This is the left posterior lung field. The probe you can see is in longitudinal orientation. And
Antonio, I'm still seeing just your standard like editable view, not presenter view.
Got it. I was wondering about that. What if I think I have to share the other screen. Share screen, screen 2. My apologies for sharing the other screen. All right, so hopefully the video clip is now running. Can anybody confirm?
No, yeah, you're not. There's no sharing screen yet.
Screen 2, share.
Got it.
Okay. So here we go. Longitudinal left lung field. We see this. Presumably the right side was fine. And so would anybody have any initial thoughts?
Hey, Antonio, I can't tell if it's from just the clip, but are there bronchograms within that?
Yeah, so what I don't think you can see clearly here. What I like to do when I do the lung zones is start in longitudinal, and if I see something that makes me sort of pause, such as this little divot right here in the pleura, then I'll rotate the probe 90 degrees, and we get something that looks like this. So this is more same location, more of a transverse orientation, and I'll let folks comment on what this could represent.
I mean, that certainly looks like more than a sub-centimeter consolidation with bronchograms in it.
Yeah, I would agree. So we have some shred, we have some static or bronchograms. I've been getting into the habit of just putting color Doppler on just sort of POCUS lesions in general. And I wanted to just point out that right next to the lesion here, there was this area of more confluence B lines. So given this clinical picture, persistent fever, respiratory distress, it's an infant, the physical exam is fairly unreliable. We felt it was probably reasonable to initiate treatment for community-acquired pneumonia. Now, what happened in this case is the breathing improved somewhat with some albuterol treatment, but the kid still didn't look perfect. And even though he was taking good PO intake and was relatively well hydrated, it was the 30-hour visit. The mom was so frightened. I think she actually described her fear of taking him home and finding him lifeless. She used the word lifeless, within the next, if she were to bring him home. So we ended up just erring on the side of caution and pretty conservatively admitted him, but didn't necessarily need high flow, or fluid resuscitation or anything like that. And then lo and behold, he did pretty well as an inpatient. I think they watched him for a day, didn't have any fever. And so the clinical team felt that everything was more likely consistent with a bronchiolitis type picture. They discontinued the antibiotics. And, it was an overnight for me. So I didn't get to it until I think the next day or the day after. I was a little bit worried, about the potential to bounce back for a fourth time. So I tried to touch base with the family, but wasn't able to, but the phone number list didn't work. And the email, I sent out an email that couldn't get a hold of her either. So, and it was a clinic patient, so it's hard to do it through the pediatrician. So what ended up happening several days later is he came back. He came back with persistent fever or rebound fever, I would say, and more respiratory distress. And at that point, a repeat chest x-ray was done with what was read as consolidation changes in the right side. And I think there's probably stuff going on in the left, and this is a little bit more of a multifocal, type of pattern, since the lung ultrasound findings were more noticeable on the left side, but on several days prior. So this is something that what could we have done better? How do we recognize how do we do knowledge translation to physicians who are well-meaning and want to promote antibiotic stewardship, but at the same time may not be as comfortable with, say, lung POCUS findings relative to somebody calling an infiltrate on a chest x-ray, and wondering if folks had any similar experiences, or how much, in patients that are keeping in the hospital as opposed to you're discharging from the ED, because I think if this little guy gets discharged from the ED, the treatment will be different from an antibiotic standpoint. But anyways, opening up to the floor just to see if there's any shared experiences or any insights on these sorts of issues.
Antonio, do you know what made him like switch the diagnosis to bronchiolitis? Was it the lung exam? Were you able to tell, or?
Yeah, so I reached out to the team. There was a thought that because the rhinovirus test was positive and you know, in the hospital setting, didn't have any recurrence of fever, and the respiratory exam had sort of stabilized to some extent. That I believe that was the thought process for discontinuing the amoxicillin at the time.
Antonio, you may have said this, but was it communicated to the inpatient team about your ultrasound findings, or were they maybe just going based on the X-ray? Okay.
It was communicated, documented, and again, it's an overnight, so it wasn't a sort of wake up the admitting attending in the middle of the night type of you know, discussion, or there didn't seem to be a need for that. But yes, and we had initiated treatment in the ER, so just trying to pull in sort of thoughts on
Antonio, isn't this kind of, I feel like we've sort of had this discussion, but when no one else knows anything about lung ultrasound, would that, in hindsight, would that have compelled you to get the X-ray and the ED just to provide the evidence to the inpatient team?
So I thought about that, Zach. And in general, our lung ultrasounds, we want to match them with some sort of imaging, and because the child had an X-ray done, you know, several days before, we had something, you know, in terms of something else, something to compare to, although the timeline is different. I wasn't convinced, Zach, that what we saw by lung POCUS would have even been picked up by X-ray, and I felt that if that was the case, it would have made it even more likely for the treatment to be discontinued from a CAP standpoint. And an infant who, it's really, you know, if you're thinking pneumonia, it's strep pneumo, as opposed to some others. I didn't mention that the COVID test was negative on this kiddo on the first visit when he had the rhinovirus test positive. So.
And Antonio, I don't know if I missed it or didn't see it. Did you get labs on this kid when he was admitted? Basically looking for inflammatory markers.
We didn't. We didn't feel the need, you know, to go down the procalcitonin and leukocytosis, and with a cardiac ultrasound, I had mentioned the cardiac ultrasound was okay, had nice function. So again, some improvement after the albuterol treatment. He was generally well hydrated. This was probably likely an outpatient management, you know, 9 times out of 10, but just given the time of they had presented, and we don't really have a dedicated OBS unit and a mom who was quite frightened. This is, you know, what led to keeping him in-house. But you know, I think it's helpful just because we were able to follow the progression of illness in different settings and can hopefully do some education around it. So I don't want to get too hung up on this, but I just thought it was worthwhile sharing. And if folks want to, you know, give me some offline recommendations, that'd be great.
Well, I think now you have the result too that you can go back to the team with and say, you know, this was sort of the outcome, and sort of have a discussion around that, or, you know, sort of going forward into like a QI project or something. But now, I mean, you have sort of a good case to present to them to sort of argue maybe for trusting your POCUS more.
Okay,
Yeah.
Go ahead, Lay.
the side was discordant. I mean, the second X-ray finding was on the right side, and the POCUS finding on the left. Yeah, I think that, you know, POCUS lung is, I'm not a convert just yet. I do think there's, I mean, the whole idea of pneumonia is one of those things that's pretty ill-defined, I think, clinically as well as radiologically. So it's very hard to say there's a concordance between lung ultrasound and clinical course and or chest X-ray findings and or physical exams. So I think it's a very interesting area. I mean, on Jim Sung's study from 10 years ago basically said if they treated everybody with lung ultrasound findings consistent with pneumonia, they would have treated 20% more kids with antibiotics and, you know, without really demonstrating benefit or outcome improvement. So it's an interesting subject, but I just think with so many confounders and lack of gold standard, it's difficult to do a prospective evidence gathering. So anyway.
Yeah, unfortunately, I think with ultrasound, at least my experience, I've had the opposite experience where it was like really sick looking bronchiolitic sort of baby that when you ultrasounded their lungs, they had what looked like air bronchograms, like diffusely. And when the kid got up to the PICU, they actually discontinued those antibiotics as well, and the kid did absolutely fine. And so unfortunately with lung ultrasound, I unfortunately have to say to many people that clinical correlation is required, because I have seen atelectasis. It's really hard to distinguish atelectasis from consolidation in these little babies. And so I really rely on some of the other clinical indicators to figure out whether to give antibiotics or not.
So we've got 27 people in this room. I know we've got access to many others, but I think this would make a great, simple study, similar to how the adults did their cardiac arrest one, where they had 30 clips and asked people, what do you think, dead, alive, or something in between. We, get 30 clips of lung ultrasounds and send out to everybody in POCUS and get their opinions on what they would do with that image, just to find out where we stand on how we agree or disagree with any of this stuff. And I totally agree with, what you guys have said, that there's a lot of disagreement on how we interpret and how we apply it.
Isn't that what Marsha sent from LA? Like, did you guys get that? Like this massive, giant red cap case-based thing? No, it was all like lung cases, and it was part of a study. Did you guys get that, or I was only so lucky?
Yeah, no, I got it. I got it and spent the hour and whatever it took to fill it all out.
So I think, that may address some of that, no?
I think there's also so much in terms of like what machine everyone uses and what setting you're using and whether a beeline looks like a beeline or a little divot somewhere.
Yeah, Lily, you studied this, didn't you?
Yeah, it was my fellowship research. I did and it had to be stopped with COVID. I enrolled 70 kids, and I was comparing 4-pass versus a complete 12-pass ultrasound. And I think the 4-pass does pretty darn well. I've passed it on to the next fellow who will hopefully complete the project. But yeah, I'm a big proponent of the transverse views, but it doesn't still take away from the existential crisis that is what is pneumonia, period.
Yeah, I agree with everything that's been said so far. All right, so moving on to another case. So this was also fairly recent. We've had a bolus of eating disorder and anorexia patients these past few months. And this particular male presented with weight loss and bradycardia with a heart rate to the 40s, 50s, a normal blood pressure, and had a 35-pound weight loss in 6 months, attributed to sort of, excessive exercising and restricted caloric intake. And so there's no baseline weight that was available, but 16-year-old under the 50th percentile, and had a cardiac ultrasound done. I had a tough time extrapolating from the medical record if it was due to a little bit of chest pain or shortness of breath, or it may have been only due to the bradycardia. So these were the images that were obtained. You have a parasternal long, parasternal short, and call it an apical 2.5 chamber. And I think we can all see the sliver of an effusion, which, got the treating team worried enough to discuss with the cardiologist, and then our cardiology teams was consulted, and they sort of did an echocardiogram and confirmed the function was okay and confirmed the presence of an effusion, and then they sort of shrugged their shoulders and we're essentially, doesn't need follow-up from us as long as the nutritional deficits are corrected. So I did a little looking at this question, and it's mostly been sort of described in case report type format, but there is an association with anorexia nervosa and the presence of pericardial effusions. So nothing too rigorous in terms of, it's mostly observational, retrospective, case report type stuff. But every once in a while, you may have an adolescent who not only has a pericardial effusion, but may present with a significant amount of fluid collection to require, pericardiocentesis. So I guess that's the only asterisk here. If we have a eating disorder patient with bradycardia, but they're also having additional symptoms to suggest, compromise of their pericardium, those are the ones I'd probably take a look at moving forward, but I don't think I'm routinely gonna do cardiac ultrasounds on bradycardia patients who have anorexia and need to come in for sort of weight stabilization and things like that. But I don't know if any of you have had any similar exposure or something along these lines. I'd love to hear. And if not, we can move on to the next one because there's tons of stuff to get to. So here's another challenging case that we've had recently. This was a 15-year-old female with type 1 diabetes who presented with elevated glucose at home and some non-specific symptoms, some weakness, some dizziness, some fatigue, afebrile without cough, and had already had a negative COVID test. And sort of she described with these symptoms, and the team felt that she was anxious, but she described there was some pressure in the chest, and she wasn't really short of breath, she just had some pressure in the chest. Her initial heart rate was 120. She had, I'll go over the EKGs in a second. On the EKGs, her heart rate came down a little bit, but still with some tachycardia. And sure enough, she was hyperglycemic, but not in DK, no acidosis. And the team had sent a troponin. It came back, it was negative with this idea of having pressure in the chest. Pretty unremarkable CBC and pretty unremarkable electrolytes. And as you can see on this EKG, the reason this EKG I think was repeated is it was probably done pre and post hydration, pre and post fluid bolus to see if there was any change. And if you look at lead 3, you can see an inverted T wave. And if you look at lead V4 and V5, you can see additional inverted T waves and suggestive of maybe a S wave in 1. It's certainly isoelectric in 1. Tiny little Q in lead 3. So knowing this is POCUS conference, anybody have thoughts on what could be at play here? How about with this ultrasound? This is helpful for anybody. So
a little bit of septal, like sort of paradoxic septal movement towards the LV versus RV.
Yeah, this is not the I agree, Matt. This isn't the best spot probably to look, in terms of the parasternal short. And I started became aware of this case the next day, looking at these images when I'm doing my QA. And what I saw here in the right ventricle was just more echogenic sort of filling that I was typically accustomed to seeing. But I sort of said, well, it's so low. Let's see if there's a clip more at the papillary muscle level. And then here's the clip at the papillary muscle level.
See almost a D shaped of them.
Yeah, I agree. So again, the POCUS conference review, I'm going to bring some abnormals for you to sort of pick on. I thought there was a flattening of the septum, and not only flat, it seemed to be bowing in towards the LV as well. And the RV was generous. And, I think there was some discussion at the time by the clinical team whether this could be a big RV or not be a big RV. And, they obtained an apical 4, and then the apical 4, this is the best view that was recorded. Doesn't generally mean the best view that was obtained, but the best view that was recorded. And so this felt to be reassuring from an RV strain standpoint. I think we have to consider where the apex is relative to where the probe is, and appreciate that we're off center here. What would you guys do if you were in the moment? This is your patient and you're driving the probe. What's some
sound to see for like a PE or with the inverted T waves and the RV, dilated RV?
Mm-hmm.
Throw the probe on the lung a bit and just to fish around, maybe.
Yeah, lung ultrasound, certainly for B lines and things like that. Anything you would do potentially in this case, and even just in this view, just to adjust it a little bit?
We don't talk about it as much, but the TAPSE looks very poor. I mean, that's one thing you actually sort of can see in this image.
Oh, that's interesting, Zach. You think even without an 8-color Doppler, you can make an assessment there? I mean, you're the pro of the group, certainly more so than me on this.
Yeah, so TAPSE is just looking at the junction of the tricuspid leaflet with the free wall of the RV. And it's actually like one spot on this image that's pretty clear. And the RV contracts in 2 dimensions, whereas the LV contracts more concentrically. I don't know that it's been studied in pediatrics at all, but you want to see good movement of that spot where the tricuspid valve meets the free wall. And it just looks to be kind of pitter-pattering around. I'm not seeing like up and down motion at that spot.
Yeah, I thought the septal movement was off, as you say, sort of like deviated in both directions on this clip. So having never actually diagnosed a McConnell sign, but I thought it would just at least be useful to just review it. It's a clip from 5 Minute Sono. And, the difference here is that the septum lines up right where the probe is. So you have this trampoline sort of hyperkinetic movement of the RV apex. And perhaps this is a specific finding for acute PE versus other causes of right-sided, strain or failure. So what ended up happening in this case is reached out to the team. There were both the cardiologists were sort of involved at the time, but again, I think PE necessarily by focus is not something that's in their wheelhouse. So she ended up being discharged from the ER, and she had an echocardiogram done several days later. On this echocardiogram, she had incredible thrombus burden that was seen by echo, both in the RV, which I think you could see some suggestion on that apex view where the parasome was short down to the apex, and also the pulmonary arteries. Luckily, she made it back to the ER with this degree of clot burden. The RV thrombus was confirmed by CTA, and this was felt to be an acute on chronic picture just because she made it to several days out. And I just wanted to bring this up as a sort of a quick shout out to our colleagues down the hall. Our emergency medicine team sort of looked at this and published it not too long ago. They looked at focus and focus findings and their test characteristics for PE. And so this was a prospective and multi-center study, and they enrolled about 143 patients. And they used a positive focus, as their what they compared to their CTA as a criterion standard. And if there's any dilatation of the RV, any McConnell sign, any septal flattening, or as Zach just mentioned, abnormal TAPSE or signs of tricuspid regurgitation, this was felt to be a positive focus. And so I think the interesting thing here, the prevalence of PE was 27%, but the interesting thing here is that for the patients with extreme tachycardia with more than 110 in terms of their vital signs, the sensitivity of this cardiac ultrasound was 100%. Now the specificity was poor in the 60s. I think if we were able to realistically do this in a pediatric population, perhaps the specificity is even higher for patients that don't have other sort of chronic medical conditions that cause issues with the right ventricle. But thought this was important to just review.
Antonio, can I ask a quick question?
Yeah, of course.
For more of the veterans out there. So this is the scenario that like scares me to death. If you hadn't done the cardiac ultrasound, I think that's like standard of care, right? They went home, they got worse, they came back. But someone did the POCUS, and you could argue it was abnormal. Like theoretically, this patient could have died at home. I don't know. That sequence of events is frightening.
Yeah, I mean, it was terrifying for me, Zach, when I looked at the images the next day, and realization that folks were sort of had an inkling of what they were looking for, but not having necessarily the level of experience that some other of our faculty have. But you're right. I've thought about this case quite a bit. Part of the reason why I wanted to talk about it. And so we're tweaking some things where we're, from my end, trying to be a little bit more hands-on, and we've always had a policy. If you have any questions when you're doing a scan, reach out to us. Doesn't matter when, time or day. And by us, I mean Julie as well, because I've sort of I've dragged her into this POCUS QA realm. But I'm sort of beating the drum louder now, to some degree, it was some level of luck that I got to it the next day, and so now I'm really, because we are 100% QA. I know we've had this conversation before, and it used to be when we're doing not as many scans, maybe I get to something 2 or 3 days later, but now I'm logging into QPath multiple times a day when I'm home, and sort of, I don't think there's a perfect answer, Zach. Yeah, this luckily was not ideally, this is a great catch when we're sort of delving into this rare PE world now that COVID's around, even a little bit more frightening, but it ended up being a near miss. So we can talk about it, or I can bring it to the forefront. She was successfully treated on readmission and anticoagulated, and is currently on Lovenox. But she'll have follow-up CTA probably several months from now. But if anybody else has thoughts on how to best navigate, I think Zach brings up an excellent point.
You mentioned cardiology echo a couple of days later. So when you saw this, you called her back and told her to come in, or no?
So that's what I should have done. I entrusted it to the team that spent hours thinking about her and managing her, and sort of, there was a follow-up touch point made. She didn't seem to be getting worse the next day, so they felt that they could wait to have. Somebody did call, yes. Yeah, but it wasn't myself. But I think this is one where next time I'm picking up the phone and sort of explaining to the team after type of thing, as opposed to trying to do it through the team first. Sort of weighing the two alternatives at the time. But yeah, no, we did have a next day phone call put out, Rosemary. It might have not have been enough, though.
Yeah,
what I struggle with.
When this happens, which doesn't happen that often, obviously, but the QA, like we ourselves call and say, hey, how you doing? If it's like some free fluid in a belly that somebody called negative, because if they're fine, they're fine. Oh, I don't have any more pain. Oh, I feel good. Okay, great. And then we actually documented in our EMR saying we talked to them, we saw this like maybe discrepancy and she's doing fine, and we told her to follow up with her PCP or whoever.
I'm pretty impressed, Antonio, that you got to this the next day. You know, for me, I find it very difficult to do QA on at a timely basis, and I put a lot of the onus on the attendings making the clinical decisions based on their scans to get it right. And if they're not getting it right, then they need to take responsibility for it, because the problem that we're having is that these attendings are not scanning enough. The residents are scanning a ton, they're saving images, and ultimately the attending of record is responsible for those scans, right? And so I feel like it's a lot to ask for the POCUS QI person, at least in our setting, and probably in yours if you're, you know, there's like 2 of you overseeing all the scans in the ED, to have that onus placed on you. I don't know what other people think. I feel like it's a lot. So I never set the expectation in our group that you know, QI is going to happen necessarily in a timely manner, because it's impossible.
And I know we discussed this before, but I don't know how often people in the group like do QAs. I mean, I do it once a week. This is my worst nightmare. So I don't know how, like, people are doing more often than a week. I guess if there's more people in the department.
So in my group, we have 4 machines and we do QA for peds and adult, but we only do it once a week, and by no way, shape, or form are we anywhere close to 100%. Don't even want to guess what percent. But the attendings are credentialed. This is part of their privileging for the hospital. And so, as Erica said, they're, you know, if they're credentialed for doing it, it's on them to get it right. It's on us to make sure that they're consistently getting it right and having, you know, interventions if they're not. But I think this would fall back on them. And, you know, I like the idea of having good communication. And I do like it when my fellows are attending calls, you know, at any time of day about a questionable case, and, you know, sometimes do some like FaceTime live to go over it. Adib was one of my fellows, had a cardiac case a couple months back that we sort of did that way. But yeah, I mean, this is a great discussion. We could probably have one of these meetings not about, you know, individual cases, but just about like administrative stuff.
Can I ask our group, we don't have a lot of attendings who scan. So Adam and Erica, how do you guys, what do you do when there's a case where sort of the attending hasn't recognized the pathology? How do you guys handle that, or who handles that?
So, I mean, we do documents, you know, everybody that does the imaging, they report with their findings in the EMR. And, you know, if we pick something up that's discrepant, I'll usually, you know, reach out and talk to them first and find out like what, you know, sometimes there's things that happen that don't make it into the EMR. And then, you know, depending on what's going on, somebody has to call the patient if we think that it's, you know, something that deserves them to be notified and to come back in right away. So sometimes, you know, the onus is on the person that saw them initially. Sometimes it's on me, and that's okay. Or, you know, one of the people that does the reviews. I have a couple other adult attendings that do it with me, since again, it's a mixed review session.
Yeah.
So our hospital has a pretty good QA system in general, not necessarily related to POCUS, for follow-up, for callbacks and things like that. So I actually have done it before, where if I can't reach the patient myself, I'll punt it to the QA nurse and say, hey, can you get in touch with this family, because, you know, such and such, whatever it is. And she'll usually manage to get in touch with them on my behalf. But honestly, it doesn't really come up that often, because our attending group is most comfortable with like soft tissue stuff. They don't make a ton of, you know, cardiac related decision making like this one. And so it hasn't really come up all that often in our center.
So I think I know Julie wants to finish to work her last case. So I'm gonna save items 2, 3, 4, 5 on Antonio's top 5 things to scan for next time we're invited to present. And then Julie, do you want to try to see if you can get your case in. I'm going to stop sharing my screen.
Okay, thanks. Yeah, I'll see if I just in 1 minute just finish the case. What's going on here? Are you seeing? Let's see. Are you seeing my screen?
Yeah.
Desktop.
Okay, great. So here are the sagittal and transverse pelvic views. I'll just give you a moment to take a look. Feel free to share anything that you notice.
And you got
Like a big old ovarian cyst.
Yeah, exactly. So here's the large cystic lesion over here. Here's the ovary, and then the bladder is over here.
I think we lost her again.
Julie. Pay your utility bills.
So I think I think we lost her. So I think we'll cut her off. It's at 2 o'clock already, so we'll stop her there. Definitely interesting discussion. So I'll have Antonio present in the next upcoming months. So, but other than that, that's pretty much it. So thank you, everyone. Next week, Lori Malia from Columbia will be presenting. So hope to see everyone there. And then I'm sure Julie is going to want to hop back in. So we'll let her present also coming up soon. Any other questions or concerns, just let me know. But thanks for everyone for coming.
Sorry about that poor bandwidth. We'll figure it out for next time.
No problem, Julie. Thank you.
Thanks, guys. Take care.